Good evening, everyone. My today's topic is on intraocular foreign bodies. Introduction. Major cause of monocular sudden blindness is open globe injuries, which are preventable in 90% of the cases. Intraocular foreign bodies are defined as intraocularly retained unintentional projectiles that require urgent diagnosis and treatment to prevent blindness. IOFPs account for 16 to 41% of open globe injuries and frequently cause severe visual loss in patients of trauma. The visual prognosis depends on the zone of injury, type, size of the foreign body. The materials and methods used in case 1, there was a 50-year-old male patient who came to the emergency department who suffered injury to his right eye after a tree branch fell on his eye. He complained of profuse bleeding and visual loss in his right eye. A second patient was a conscious cooperative 42-year-old male patient that came to ophthalmology OPD after suffering trauma with wooden particle while he was working in a sugarcane factory. As you can see the two images on the screen, the first image shows us the tree branch in his eye and the second is a small particle inside the AC. The visual acuity at the time of presentation for case 1 was only perception of light present in the first case, and the second case had good visual acuity of 612. In case 1, the eyeball could not be visualized, the foreign bodies were seen protruding from the orbit and fresh bleeding was seen at the point of entry. Multiple lacerations were seen periorbitally and on the right side of forehead. In the second case, we were able to see a IOFP measuring to 1:1 at 6 o'clock position. There was also a 2.5:1 mm corneal tear with iris incarceration. We explained prognosis to the patients in both cases. In the first case, a grim prognosis was given to the patient and the relatives because we could not visualize the globe and there was profuse bleeding. The depth of penetration of the wooden sticks could not be judged and the patient was taken for emergency OT. Also, most importantly, we gave references to OMFS, ENT, general surgery, and they were asked to remain standby. In the second case, a favorable diagnosis was given to the patient. We were told that since the globe is intact, the vision is intact, so our plan was to go for surgical management and we explained the chances of infection to this patient. For management for case 1, a visible foreign body was removed with the help of forceps. On removal of the foreign body, the globe was found to be completely intact. The foreign body had lodged itself inferior to the globe, pulling the closed upper lid down in the process, protecting the globe. So what we thought was an intraocular foreign body turned out to be an intraorbital one. And this patient was extremely lucky that his globe was intact. In the second case, we posted the patient for OT and the IOFP was removed. We had done iris excision, corneal suturing, and we restored the anterior segment integrity. Post-operatively, we started the patient on antibiotics, antifungals to prevent infection and promote healing. So this is the first case where tree branch had completely obstructed the view of the eye. We could not see anything. After we removed the foreign body, we saw surprisingly the globe turned up and we were able to see the eye. Conjunctival tear was seen, subconjunctival hemorrhage was seen, full chamber blood clot was seen. Patient gave hand movement close to face vision. After on the 4th day, as the blood clot started resolving, the patient's vision started improving and up to 6:18. Again saying that this patient was extremely lucky, the management was very prompt. CT face and orbit for the first patient was done and we found orbital floor fractures. For this, the patient was referred to OMFS. We again want to say that we want to emphasize the importance of imaging and careful exploration of the ocular trauma to avoid mixed diagnosis. As we said, we thought this could have been an intraocular one, but this was actually an intraorbital foreign body. Post-operatively, for the second case, we had done iris excision for that patient, corneal suturing, and IOFP was removed. For this patient, 5 corneal sutures were taken. For the two cases, the ocular trauma foreign body presented very differently. The first one was intraorbital, the second one was intraocular. This contrasts the outcome, highlight that no two traumas are alike, so none of our evaluation or management should be alike. It should all be different and should be tailored to their specific issues. In conclusion, in our tertiary care hospital in a rural setting, we frequently encounter ocular trauma with varied foreign bodies ranging from small intraocular one to large intraorbital one. We want to highlight the severity of trauma that can differ dramatically, and we also want to say about the long-term follow-up of this patient. We want to prevent complications such as secondary glaucoma, cataract, corneal scarring, and endophthalmitis.